No audio.
Welcome and good afternoon. We are so grateful for you joining us on this first week of 2023 for our behavioral health community of practice. Thank you all for being on today. My name is Trudy Matthews. I'm Senior Director of Quality and Value Strategy at UK Healthcare and also Executive Director of the Kentucky Regional Extension Center here at UK. And the behavioral health community of practice is one of our ways as the University of Kentucky of really reaching out into our communities across the state to deal with some of our challenges and issues that healthcare providers and our partners across the state are dealing with. I think we all know what a huge increase we've seen in behavioral health concerns. And so we're delighted to have with us a number of experts from the University of Kentucky, also our partners New Vista, to talk today about pharmacological interventions to deal with behavioral health concerns in primary care, some evidence-based guidelines. And so we'll be addressing both adult and child concerns. So really excited about our speakers today, as well as our panel discussion. A couple of things for folks who are newer to our community of practice and who've also been on other ones. The name of the game today is really interaction. So we hope that we have good interaction today, and we're going to do that through a couple of ways. So first of all, for those of you, many of you probably are very familiar with Zoom, but just want to make sure that you're familiar and bring up the chat feature, because we are going to be asking folks to put their questions in the chat. We're also going to be using QR codes, so have your phone handy, please. We're going to be asking you to respond to a survey and then also sign up for mental health first aid training later in our session today. So I want to make sure you have your phone handy to do that. And then also we're going to be using annotation today and a Jamboard. Now the Jamboard instructions will come later, but we're going to test out our new interactive features on our annotate slide. So coming up, on our next slide is how are you all feeling today? We want to get a sense of how you're feeling. I love the cats and dogs on this slide. If you all are not familiar, usually at the top of your screen or at the bottom, there's a black bar, and there is the opportunity to use what's called the annotate button. And you can look on that, you can click on annotate on your bar, and then should come up a text, stamp, or arrow. I'm going to show you today. I'm going to put super happy on the screen. Trudy Matthews, hopefully you can see there that I clicked and put my name next to, with an arrow next to super happy. You can put a stamp with a star or a heart. And if you just go ahead and participants, go ahead and fill out how you're feeling today using the annotate button. We'll see whether folks are able to follow along. Let's see, anybody else responding? How are folks feeling today? You can also, if the annotate button is a bridge too far, thank you, Teresa, that was great. Oh, tuned in. I like the dog, has a lot of hearts on his face. That's great. Content, I like the cat. It's been a little bit of a rough day. I hear that as well. Some days it can be kind of tough. Hopefully we'll have some good information to provide today. All right, well, thank you all for using that annotate feature. We will hopefully be using that both today and in future sessions to get your all's feedback. All right, with that, let's go ahead and get into our content for today. Our first speaker, we're so delighted to have Dr. Sarah Oros, who is Assistant Professor of Psychiatry in the UK Departments of Psychiatry and Internal Medicine, and who is Program Director for the Combined Internal Medicine Psychiatry Residency. And her specialties include General Internal Medicine, Geriatrics, Primary Care, Psychiatry, and Women's Health. And she's going to be talking with us about pharmacological interventions for adults today. So thank you so much, Dr. Oros, for being with us, and take it away.
Thanks for having me. All right, well, let's get started.
If you could go ahead and advance the slide. Um, excuse me. Today I'm going to discuss some of our suicide statistics and evidence-based strategies to help mitigate suicide, as that's something that I think primary care is increasingly seeing and being expected to manage. And then I'm going to review prevalence of mental illness and first-line treatments for depression in our time together. As far as suicide rates go, this is a graphic from 2020, our most recent data from the CDC. And on the left, we have females, and right on the males. And as you can see, males have a much higher suicide rate. It's about stable until you hit 75, and then the rate goes up. So that's really our population at most risk. All right, next slide, please. And then as far as ethnicity goes, just very quickly, most at risk are our American Indian population, followed by whites, and then Hispanic and Black, and then Asian. And then as far as suicide rates by state, the dark blue here in the United States is the worst on this heat map, and then white is lower rates. And as you can see here in Kentucky, we're not the worst, but we also have some ways to go. So we're at kind of 17 to 19 here. And then as far as screening goes, we know that 50% of patients who have gone on to die by suicide have presented to their primary care provider in the 1 month prior. So they have they've been touched by primary care. It's actually much higher than those presenting to a dedicated mental health provider. The Joint Commission does recommend asking about suicide in the outpatient setting. And the United States Preventative Services Task Force has insufficient evidence for screening for suicide, but does recommend depression screening. As I was just reviewing the guidelines this past week, the website does say that it's under review. So I don't know if they're getting ready to change their recommendation in asking about suicide, but it's something that's debated, and it's something here at UK we've incorporated in the outpatient setting. I do want to talk a little bit about asking about suicide. This was something I received a lot of training in my psychiatry residency, but on my internal medicine side, it was actually never talked about. So I'm going to go just through some of the questions I usually ask patients. It is important to establish rapport before diving, into direct questioning, so the person feels comfortable about talking and being open about some of their thoughts. I usually will ask about passive suicidal thoughts first. So have you had thoughts about not wanting to be alive, or have you felt like it did not matter if you woke up? And then if a patient's saying yes to these questions, asking more directly about active suicidal thoughts, such as, have you had thoughts about wanting to harm yourself? Have you had thoughts about wanting to kill yourself? And then have you gone so far as to come up with a plan? And if they have, please advance next slide. Talking about, what they've thought about, have they made preparatory acts? And how long have these thoughts been going on? And in all of this, have they ever done anything to try to end their lives in the past? And if they have, what came of it? So, was it something where they took 2 Benadryl, went to sleep, and thought that was going to end their life? Or did they actually, sit with a gun and think about shooting themselves? And then what precipitated these thoughts? So is this something that, they just lost their job? Maybe they're undergoing a divorce and it's led them to this point. What's happened? And how has the patient previously dealt with some of these thoughts or ideations? And then asking about hopelessness, I think, is very important, as that's been a predictor of suicide. So does the patient feel hopeful that things will get better for themselves? And if they haven't, or if they don't, that kind of just should, maybe make you think about an intervention. Next slide, please. So what makes a difference? What have the studies shown? So actually, education of general practitioners in primary care has helped lower suicide rates, attempts, and ideation. There's actually mixed data out there, so some positive and some negative studies about screening for suicide risk. One of the studies was using the Columbia Suicide Screener, which is what we use here at UK. Was shown to be predictive of attempts in adolescents and young adults after a psychiatric crisis, if you will, ED. And then medications definitely have been shown to decrease suicidal ideation and suicidal behavior. So that's something that should be used as a first-line treatment. Next slide, please. Other things that have made a difference, psychotherapy, so cognitive behavioral therapy for everyone, and then specifically dialectical behavioral therapy and psychodynamic approaches in borderline personality disorder. Contact and outreach after a suicide attempt or suicidal ideation, kind of in a crisis situation. So after coming either to the ED or to a visit, that has made a difference in future attempts. And then means restriction has also been shown to be helpful in places that have restricted gun laws, that those places do have lower suicide rates. And in developing countries in which people use pesticides to commit suicide, in those countries that have restricted kind of the public access to pesticides, that definitely has decreased the suicide rate. So, if a patient's coming in with thoughts, asking about firearms, and then talking to either the patient and or the family member about restricting it is very important. And that's something that you can do that will make a difference. And then moving on to talk about generally mental health. This is the past year prevalence in 2020. So about 21%, and then these are all comers. These aren't patients that present necessarily to a primary care office. And I think for those of us in primary care, you can probably attest to the fact that it's much higher than 21%, but these are, kind of everyone. And more females than males, and then more so in our younger folks. Next slide, please. And then of the patients that do have mental health concerns or any mental illness, these are the patients that have received services in the past year in 2020. And so on the left here overall, 46%, so less than half, have received any type of mental health service. So, there's still a fair number that we're not capturing, and more females than males, and less so for our younger folks that are older folks. And somewhat of a ethnicity skew. As far as depression treatment strategies, and I realize this is just a small kind of piece of the pie, first line are selective serotonin reuptake inhibitors. You don't have to use this as your first line, and certainly if there's an indication to use something else, you can. This is what the literature suggests. If a patient fails, if they have a side effect or the medication is not working, it is still recommended to try a different SSRI or an SNRI. So if your patient's dealing with chronic pain, it may be worth trying an SNRI. If a patient fails two SSRIs, you can switch to a different class. So if you haven't tried an SNRI yet, moving to that, a tricyclic antidepressant, or if they've had some benefit with the medication or at least no side effects, you can try adding on a medication to help boost the effect. And so one of those medications could be bupropion or mirtazapine. If a patient is anxious, you can try and augment with buspirone or a benzodiazepine. I typically don't just add these on kind of willy-nilly, but these are what the guidelines suggest you can do. At each point in treatment, you should be assessing psychosocial stressors. So how's everything going in the patient's life? Psychotherapy can be offered first if a patient prefers to try that and would like to hold off on taking medications. And then regular intervals of follow-up. So, starting a patient on a medication and seeing them back in a year is probably not appropriate. Seeing them back in 4 to 6 weeks is usually kind of the typical interval of follow-up. And then, if a patient's not getting better, what should you be thinking about? Asking about trauma is very important. And I find in a number of patients, that's kind of the underlying issue that's causing some of their symptoms. So asking about that. Ongoing substance use can certainly make treating mood a lot harder. So asking and screening patients for that. And then things that I think maybe more kind of getting into a psychiatry referral, personality disorder, and whether they're secondary gain. These shouldn't necessarily be on the forefront, but just things that can be kept in the back of your mind. All right, and then reasons to refer to psychiatry, suicidal thoughts. And I started this, I realize again that it can be difficult to get patients in to see psychiatry. And so you may be left managing it. And hopefully some of what we've talked about today can make that a little bit easier. Potential mania, so if there's concern for a prior mania, or if you've sent your patient into mania by a medication. Psychotic symptoms, it's just hallucinations, paranoia, treatment-resistant symptoms. So again, maybe you've cycled through 5 or 6 different medications and nothing's working. And then, if a patient's asking or they've tried a number of medications and you're thinking about maybe something more advanced, such as electroconvulsive treatment, TMS, ketamine, or esketamine. All right, thank you.
So we want to make sure that folks who are on the line know to use their chat to ask questions. So we don't have anything for you currently, Dr. Oros, in the chat, but I did want to follow up and just ask, from your perspective, because I know you deal with both internal medicine and psychiatry, so you have kind of a foot in both worlds. How do you see the management within primary care of individuals with behavioral health conditions? Is, I think we're trying to kind of help increase the confidence level for primary care practices to manage and to what percentage of patients do you think can effectively be managed in in a primary care setting from your perspective?
Yeah, I think a fair amount can. I think when you're getting into some of bipolar or schizophrenia, that gets a little bit trickier. And even patients that have trauma that, haven't had therapy for it, that can also be tricky. But I think many of our patients can be managed in the outpatient setting with close follow-up. And I think we probably know there's probably not enough mental health providers in to see everyone that should be seen, needs to be seen. And so there's a lot that are left in the primary care setting. And I certainly have patients that I see in my primary care clinic, and I have colleagues that will try and refer patients to see psychiatry, but patients either don't feel comfortable or don't have the resources to get in to see someone. And they come back and they see primary care, even though that would be what everyone's most comfortable with. So I don't know that I have a good statistic, but I think a lot of patients just end up in primary care. And I think if you have a good relationship with them and can get them to come back, that actually is a lot. And that's, I think, a lot of some of where therapeutic action lies.
Perfect. Yeah, great. Thank you so much. I really appreciate you providing a great overview of the evidence, and I'm sure that we will come back to you with some questions potentially during the panel section, and certainly folks may have additional questions they want to direct to you in the chat. Thank you so much. We're going to go to our next presenter, Dr. Amy Meadows. And thank you so much, Dr. Meadows, for being with us. Dr. Meadows is Division Director of the Child and Adolescent Psychiatry Division, and is in our UK Department of Psychiatry. And she currently runs the Pediatric Psychiatry Consultation Liaison Program at Kentucky Children's Hospital as well, and is an Associate Program Director for the Triple Board Program at the University of Kentucky. So she specializes in evaluating and treating children and adolescents with complex concerns. So she is very well positioned to give us an overview of the evidence around children. Thank you so much, Dr. Meadows, for being with us.
Absolutely. So I'm delighted to, like Dr. Oros, I'm also trained in pediatrics in addition to psychiatry. I think that there is a lot of important kind of crosstalk and relationships that the fields can have. And certainly taking care of someone's physical health includes mental health. So I think that it's really important that all of you are learning. So if someone could advance my slides, please, that would be great. So I'm just going to go over kind of the practice gap, which is that in primary care, even though there's not a lot of training in mental health, primary care providers still end up taking care of depressive disorders and other psychiatric conditions. Next slide. And so my hope today, this is a very brief presentation and it's kind of a 30,000 foot overview, but my hope would be that we're able to kind of give a little bit of guidance and provide some of the information and the evidence about the pharmacologic treatment of adolescent depression. Next slide. So I just wanted Dr. Oros's information very much applies to adolescents. A lot of the same features that she talked about also apply to adolescents, but that sometimes depression can look a little bit different in adolescents compared with adults. And so I wanted to highlight that sometimes instead of saying, I'm depressed, teenagers can say, I'm bored, which is a very common way that they express depression and anhedonia. And it may be that they're more irritable, or that they have somatic complaints like headaches or stomach aches, saying, I can't go to school. They may have social withdrawal. Previously, they had been very, active, engaged, and are now isolating to their room. It may take them longer to do things, or they may refuse to do things that were previously easy for them, like homework. So just sometimes it takes a little bit higher of a threshold to kind of have a suspicion for adolescent depression, and sometimes you have to ask specific questions. And so it's really important just to have that on your radar. So next slide. And I wanted to talk just a little bit specifically again about adolescents and youth suicide. So suicide is the second leading cause of death in kids 10 and up. And that has been that way for almost a decade now, when it surpassed homicide as the second leading cause of death. And the most recent statistics are that about 1 in 5 adolescents at some point during their high school or middle school years will have thoughts of suicide, and even daily thoughts of suicide. So pretty intense thoughts of suicide. And about 1 in 5 adolescents are diagnosed with some kind of mental illness. So either depression, which is one of the most common, anxiety, bipolar disorder, some mental illness that does increase the risk of suicide. And at any given time, about 25% of adolescents would meet criteria for depression. And that's actually an increase in recent years. And if you could advance the slides. One of the really important factors for adolescent mental health has been COVID-19. And I think as many people recognize, COVID-19 has resulted in just a flood of adolescent mental health concerns and crises. ER volumes for adolescent mental health complaints have skyrocketed, really. And there's some evidence that things like eating disorders and really serious mental illnesses have increased in adolescents during COVID-19. And I think, these highlight that 37% of adolescents report that they experience some sort of poor mental health during the COVID-19 pandemic. And 44% reported feeling kind of persistent sadness or hopelessness during the past 12 months, which again, we looked at the prior slide, which was kind of cumulative data that 25% point prevalence of depression. And so this is nearly double. And I just want to mention that the CDC also came out with a recent study looking at adverse childhood experiences during the pandemic, which showed a dramatic increase in 2 or more adverse childhood experiences experienced during the pandemic. And so I think it really highlights that, not only are kids struggling, but really families are struggling as well. And many of those kind of dysfunctional household stressors are really affecting youth mental health, in addition to other factors like dysfunctional internet use and some other problematic concerns. But next slide. And then this is the thing that I really want to highlight. Most depression across the country in youth is untreated, completely untreated. So about 60% of youth who would meet criteria for depression or who do meet criteria for depression are untreated. So this, I think, is a call for everyone to be screening, be mindful, and really be addressing pediatric mental health as early and as possible, because unfortunately, statistically, there are many ways that kids struggle to get into the mental health system. So if we can ease that for families and kids to start treatment in a primary care office, we're making it more likely that they're going to have a good outcome. So next slide. So I just wanted to go over kind of pharmacologic strategies. And again, they're very, very similar to adults. Next slide. Really, medication is a very well accepted, well evidence supported first line treatment for depression, as well as some psychotherapies And like Dr. Oros also mentioned, addressing kind of comorbidities. Sleep is a huge one in adolescence, and especially with devices. That kids are up sometimes all night with their iPhone notifications. They're sleeping with it right next to their head, or they've got two devices going on. They're watching TV in their room. They've got lights on all night. Their sleep pattern can be really dysfunctional. So understanding that there are some really important comorbidities and addressing those early can be important and can be things that are easily done in a primary care office. So I'm going to talk a little bit more about medication. So next slide. So really the best evidence that we have is that both medication plus therapy gives us the best chance of recovery. And so in an ideal world, if we had kids who, had immediate access to all resources, we'd get them involved as quickly as possible in both, medication treatment and therapy. And I still think that it's worth talking with families, making referrals, but as we know, sometimes that doesn't happen. And what I really want to point out is that medication treatment alone is still really good. So about 71% of kids after 12 weeks will have significant improvement in their symptoms if they're doing both medications and therapy, and about 61% will respond if they have just medications, which is really pretty good numbers. So next slide. So emphasizing that medications are first line. Medications are excellent treatments. And so I know sometimes there's reluctance to start even SSRIs in a primary care office, but they're very good, and they help kids feel better. Next slide. And then I want to kind of again highlight medications are first line. So that same study that we just looked at, the treatment of adolescent depression, the TAD study that was published in JAMA, they did a long-term follow-up and looked at kids who were in the various conditions and how they did long-term in their global functioning. And so you'll see that the first three, the medications alone, the therapy alone, and the combination treatment alone, and the combination of both therapy and medications all did relatively well 4 years out from the initial study. But the kids who received placebo for those first 12 weeks actually did worse long-term. And so, the takeaway that I have from this study, next slide, is that treatment delay can lead to worse long-term outcomes. So yes, it's completely, reasonable to talk with families about getting kids into therapy, getting them into mental health specialists. But my emphasis here is that even a 12-week delay in getting effective treatment leads to significantly worse long-term outcomes. So, while somebody's in a referral queue for psychiatry or for therapy in local areas, talking about starting mental health treatment, even if it's medications in the office, is really, really important. So next slide. So again, the most evidence that we have in kids is for fluoxetine or Prozac for adolescent depression. You can start very low, so they make a liquid form of Prozac for very young children, but most of the time for adolescents, I start around 10 milligrams, and I do dose increases about every 2 weeks and kind of assess how kids are tolerating it. I'll just mention that escitalopram is also FDA approved for adolescent depression, but we do use other SSRIs, even if they're not FDA approved, just because there are so few things that are FDA approved in kids. And really the evidence that we have is that first line treatment for medications for adolescent depression are SSRIs, second line treatment for adolescent depression are SSRIs, and then it's the SNRIs or other medications. So really trying the SSRIs first and second if possible. Most common side effect is GI upset, which is typically time limited for the first couple of weeks. And there is a risk of agitation or kind of what we think of as secondary mania. And so it's just something to counsel families on, especially if there is a family history of bipolar disorder, that some kids may actually become activated and may kind of have their energy levels significantly increase. I will say that there is a black box warning. I'm going to talk about that a little bit. And so the FDA does recommend weekly face-to-face evaluations for the first month of treatment. I'll say in practice, this is really very challenging. So typically what we recommend is to have some sort of weekly check-in, and whether that's that we have the family call, have the family do a nurse visit, make sure that we're kind of monitoring for safety, especially if there's any pre-existing suicidal ideation. We want to get them in as quickly as we can, but just practically speaking, sometimes doing weekly evaluations during the first month of treatment can be challenging. If you have a therapist already working with the kid, that can also be another good check-in or an option for kind of doing those evaluations and making sure that they're tolerating SSRIs. Next slide. And so I just want to emphasize that there have been several meta-analyses again that have really proven that SSRIs are effective, they're safe, and they're the best treatment. So this is a meta-analysis from 2016. Fluoxetine is effective for adolescent depression. Next slide. And another meta-analysis in 2017. SSRIs and SNRIs work in kids. So the bottom line is to get comfortable with a couple of SSRIs. Fluoxetine is a great one, and use that to help kind of treat early so that kids are getting their depression addressed. Next slide. And just to briefly mention, so the FDA does have a black box warning regarding increased suicidality, potential increased suicidality in kids and young adults. And so this is something that we talk with families about. We mentioned that there is the possibility of increased suicidal thoughts. However, the studies show that it's about a 2% increase in suicidal thoughts. And generally, we don't think that it's associated with suicidal actions, but it's really important to monitor and to talk with kids about how they're doing and how they're feeling. And overall, the number needed to treat for adolescent depression or anxiety is between 3 and 10, which is well within the range of what other medications that we use. Like antibiotics are generally in the 3-4 range. So these are very close to the number needed to treat for other effective medications that we use. And the number needed to harm with just one incident of suicidal thoughts is about 1 in 143. So our risk benefit strongly favors treatment. Next slide. And again, so just like Dr. Oros mentioned, thinking about when to refer adolescent depression. So, I think that the things that we would recommend kind of doing an immediate referral to psychiatry is if depression also has psychotic features. If there are complicating comorbidities, especially coexisting substance abuse, which can really complicate treatment. And again, active suicidal thoughts, intent, plan. If there's any concerns for safety, that is an instance to refer to your local ER or to engage 988, which is the National Suicide Hotline. Next. And I just wanted to mention that we at UK are working on some initiatives to help extend access to child mental health. So we're working with the local AAP and HRSA to have what's known as an access program for Kentucky primary care doctors and pediatricians. It's going to be called Kentucky Kind. And really the goal is to help train pediatric primary care providers. So there will be webinars, there will be information available, but also help to get consultation with mental health providers and child psychiatrists. So next slide. That's all I have. I am happy to answer some questions. I already see one in the chat. The question is from Dr. Jasinski. Sleep is a very common complaint in adolescents. Additional interventions. So yes, to all of the interventions that you mentioned, environmental modifications, CBTI, medication. So typically, non-medication interventions for sleep are first line. And I try to get as much mileage as possible out of the very simple kind of sleep hygiene sorts of interventions, which actually surprisingly to me, seem like they're novel information when I present them to a lot of families, talking about putting phones outside of the room, talking about having a bedtime, using the bed only for sleep, not for sitting and doing homework, not for eating, I think with, COVID, lots of people's schedules got kind of off kilter. And, I think some of the things that we would consider healthy sleep habits got thrown off. And so doing some very basic kind of education around sleep is usually my first approach. And CBTI is great. And there are actually some apps that can help. And I think for adolescents, especially, app-based mental health can be something that is really, really helpful. So there are some free CBTI apps. The VA has one, and then there are some paid ones like Sleep Rate, which does CBTI that's kind of self-paced. So those are all options kind of when we run into roadblocks. But honestly, they are more effective than medications to do the kind of hygiene CBTI interventions. And some, obviously, we'll talk about medications, melatonin, but honestly, I use melatonin often as a vehicle to get people to do buy-in to sleep hygiene. Like, melatonin works best if you lay down in a dark room and it's quiet and you take it at the same time every night. So I'm kind of adding in some sleep hygiene with the melatonin.
Dr. Meadows, we had a quick question. What is CBTI?
CBTI is cognitive behavioral therapy for insomnia. So it's an adaptation of cognitive behavioral therapy that specifically targets sleep.
Focus on sleep. Yep. Great. Thank you so much. And those, we'll try and get some links from you, Dr. Meadows, if you don't mind, to those sites that you referred, and provide them to folks after today's Zoom call. So thanks so much for bringing that up. Those resources, I'm sure, will be invaluable for our listeners. So I want to pivot now over to our panel and introduce our panel. And of course, Dr. Meadows and Dr. Oros are also still on and are available to answer questions. So we have Dr. David Hudson, who is the Chief Medical Officer for New Vista. He is actually also a UK grad. We love that, Dr. Hudson, that you're a UK grad of the College of Medicine and General Psychiatry program here, and that you've been practicing for 13 years at New Vista, and have background in child and adolescent psychiatry. And then also with us is Dr. Jenny Gottschalk, who is medical director, who's also acting chair of our family and community medicine department. And so thank you both for being here and supplying your expertise. And so I want to start just with both of you, just asking first if you have any thoughts or comments just as you were listening to Dr. Oros and Dr. Meadows present first, around pharmacological interventions for adults and children, if you all had any thoughts based on the patients that you see or that or come to your organizations for treatment.
Sure, absolutely. Can you guys hear me okay?
Yeah.
I wanted to thank Dr. Meadows and Dr. Oros. That was a great, I feel like, refresher. And I love that you were very specific about the evidence, which I think is helpful for our providers, and knowing that you're not just saying this is going to help, like you have really good evidence to support that. One thing that I was really thinking about, and especially in the adolescents, was how that delay, in starting medication could really lead to worsening outcomes. I feel like I have a more difficult time starting, my pediatric patients on medications than adults. And often that is just because of, fear or just being uncomfortable from the parent's perspective, which I think is very reasonable. But I was wondering if other primary care practices were noting that as well, with, kind of that more of a hesitation to want to take that step. And I was just thinking personally, I probably need to emphasize more in that kind of risk benefit discussion that, we really could be causing more harm by waiting rather than going ahead and giving a trial. You can always stop a medication, but if you have that delay, then maybe things get worse. And just if any of the other people in primary care kind of felt that or had ways to kind of help families become more comfortable with making that decision.
I'll say from my perspective, I think that there's still a ton of stigma about mental health. And, many times in my experience, sometimes kids are even more open to kind of discussing their mental health and treatment than parents are. And I think that that's an encouraging sign that times are changing. But I think part of the challenge is that, that we continue to kind of fight the stigma battle. And there are a lot of misconceptions. I don't want my kid to get addicted. Well, you're not going to get addicted to Prozac. That's not how it works. And so kind of trying to dig in and understand. And I know that it takes time sometimes to address those. And so if you can't fully kind of address all of the concerns in one visit, it's okay to schedule another one. I think the challenge is we just don't want you to schedule another one a year from now. Schedule a follow-up visit in a couple of weeks, present the information. Your child meets criteria for depression. I'd really like to make a referral for therapy. And I think that we should talk about medications, start to initiate some of those kind of conversations, and then kind of keep chipping away at the stigma.
Great. Thank you, Dr. Meadows. So Dr. Hudson, I'd like to go to you too and see if there was anything that came that, we brought to mind, any comments or thoughts from the presentations.
Yeah, I want to thank Dr. Oros and Dr. Meadows for highlighting how common mental health conditions are in both adults and kids. You're looking at that basically 1 in 5 number per year for both. And also for highlighting the safety of the treatments. So like Dr. Meadows was just saying in that previous conversation, there is hesitancy. I was reading an article that said medical misinformation has now exceeded actual medical information on the internet. So when people go to Dr. Google, they're going to be immediately blasted by misinformation and why it's dangerous to take antidepressant medications. And the data is helpful in relaying that to families. When families realize that, the statistics in those original research studies show a 2% risk of thoughts, not actions. There weren't completed suicides in that 2%. And that statistically in 2004, when the black box warning came out for kids and young adults, we actually had an increase in completed suicides, which has continued. So it's clearly both on an individual level and on a population level, it's far more dangerous to not treat depression than any potential risks from the medicines. And being able to relay that safety and giving people time to process it, like Dr. Meadows was saying, if families feel like you're trying to give them the best information as opposed to trying to advocate for taking a medicine, they're going to be, far more receptive, even if that takes extra time. Another tip that I use is just asking about family members' response to medicine, because that can be the barrier. And family members may have had a terrible response or have known of someone that had a negative response in the family, and they're immediately biased against any type of medicine. So being able to understand what some of the reservations are, whether it's misinformation or a negative response to someone that they know, and then be able to say, whether it's a potential side effect and how you would monitor for it and what to, and be able to educate on risk benefit analysis instead of something being all good or all bad.
As a mom of 4 kids, I can say that, gosh, this is such an important conversation, and just is really important for raising awareness, that around what the evidence has to say. So this is really good. So I want to, we're going to come back to questions, or we're going to, I have a few more questions to pose to our panelists, but we want to get you all who are our listeners engaged as well. Katie is going to give us some instructions related to a Jamboard. This is going to allow you all to put your thoughts and to join the conversation in an interactive way. So Katie, we're going to go to you and have you give some instructions, and then we'll come back to our panelists in just a minute.
Sure. Thank you all so much. I've really enjoyed all of the engagement so far, and I'm looking forward to this activity. It looks like several of you have been able to join in the Jamboard. I did drop a link to the board right in the chat. So if you want to go ahead and click on that, what I'll ask you to do is answer this question that we'd like to pose to the audience. So what are some barriers that you've experienced in treating mental health conditions with pharmacological interventions in the primary care setting? If you come over here to this left-hand side toolbar, you'll see something that says sticky note. And can you all see my screen okay? Yes. Okay. So you'll see this little thing right here that says sticky note. If you want to click right on this sticky note and type something out for me, go ahead and click save when you're done, and it'll drop here on the Jamboard. If you're not comfortable with using the technology, go ahead and drop whatever comments you may have in the chat, and we can take those and put those on the Jamboards for you. And then as we go, as we see comments populate, we will group them into various topics and ideas that are similar to drive our panel discussion. I'm right here if anybody has any questions, and thank you all for participating.
Really appreciate folks putting their thoughts up here. So I wonder if we can tackle Dr. Hudson and Dr. Gottschalk. Again, kind of looks like there's some questions related to referrals. And we kind of talked about that a little bit, and maybe Dr. Oros, you want to join in here as well. Let's talk both about, they're kind of a little bit of, like when, in terms of complexity you refer, and then also the wait times and insurance. Do you all have any thoughts on those two questions?
Sure. As far as complexity, I think Dr. Meadows and Dr. Oros highlighted some very crucial key features. If you're seeing symptoms of mania, if you're seeing symptoms of psychosis, if there's significant comorbidities in regards to substance use or significant PTSD, those are going to be complicated to manage in primary care. And that's not to say it's not perfectly reasonable to do those screens, and it's not perfectly reasonable in many cases of anxiety or PTSD where you're not seeing mania or psychosis to go ahead and start those first line medications, but those are certainly important features. And another point in working with a lot of local family practice and pediatricians, they can often tell folks, this is what I'm comfortable with. These are the medications that I use. These are the therapists that I work with. If you're willing to try this first line and it's working, great. If these things aren't effective, we've got folks in the community that I personally work with. I know we communicate well, and I trust that when we make this referral, that you'll be in good hands. So I think those go a long way, just that personal connection and communication, that there's things we can do as first line and initial, but we also plant that seed of hope that even if this doesn't give us the results that we want, or there's still complicating factors, that there's more help. Because a lot of times people will be, especially teens that are in that all or none thinking mode, they'll have the thoughts of, I finally got my medicine and I've taken it for 3 days and I'm not completely better. So having that realistic expectation about what medicine does, how long it takes to work, what are the typical startup side effects, how long those take to go away, all of those things can be done, very well in primary care. And then once folks have given those initial, first line agents a try, they're often more receptive to that referral at that point if it's necessary.
That's great. Dr. Gottschalk, I wonder if you would address one of the other questions that is here on the Jamboard, and that's patients presenting in time of crisis. And then this kind of the related one, which is, child in crisis, but the family's not supportive necessarily of getting treatment for it. So I wonder if we could talk about how you would handle that in your practice. And then any actions that you would take in those circumstances.
Sure. This definitely can be overwhelming and certainly derail your schedule when you walk in and you're like, uh-oh, this is not the regular visit that I was anticipating. But, you know, I think a couple of things. One is like talking like with, you know, your staff and kind of having a plan in advance so that you do have some things to fall back on and you're not kind of scrambling in the moment trying to figure out, okay, who are we going to contact or what we're going to do. We are fortunate to have some behavioral health people, you know, in our clinic here at Turfland that can be helpful. If you do not have that already in your primary care practice, again, thinking about making some relationships with your resources in your community or the numbers like the 988 that we talked about earlier, and what will happen if you send someone to the emergency department. So I think sitting down and take, you know, talking about the suicidality questions, figuring out, is this, I've kind of had some fleeting thoughts and we can maybe start a treatment plan here and we're going to be okay, versus I have an active plan and this person can't go home by themselves today. So it does, you know, again, this takes a little bit of time to really dig into the details and ask those tough questions. I think one thing that, you know, we've kind of thought about in the past is like, well, don't bring it up. Like if the patient doesn't mention suicide, they're not thinking about it, but we know that that's not true. Like we need to ask these details and find out really where the patient is and what they're thinking about, and determining if this is really an active problem, then we're going to have to go to that higher level of care and transfer, you know, to emergency department. If it's really more kind of passive and fleeting and maybe they've had these thoughts but we don't have a plan, then I think we get back into, you know, well, what have you done before for treatment? What are some of the options that we can offer today? Again, emphasizing that our first line treatments aren't going to work tomorrow or even next week. It's going to take a while, but we're going to, you know, be there with you along the way. I think the one with the child, that can be really difficult. If the family is just really not even wanting to kind of acknowledge that there is a problem there. So I think, again, going back to trying to educate the family, what does the data say? This isn't just me saying, hey, it's okay, but you know, we have studies, we have evidence that supports this treatment is going to be helpful, that we've done this screening and this is the diagnosis that we're dealing with. And again, even though I certainly understand access is so difficult right now in primary care, but those more frequent visits, because if they're not kind of able to really initiate that treatment plan today, we want to see them back quickly so we can continue that discussion, and hopefully each time you're getting a little bit closer to getting everybody on the same page.
Yeah, and I think a couple of plugs to kind of follow up with what Jenny supplied. So that's part of the reason why we're offering the mental health first aid training to all the participants within the community of practice, because we know that your teams may be dealing with folks who are in crisis in your office, and that training is designed to help give some additional resources for how to follow up with folks in a crisis. So definitely, you know, we're going to have our QR code to sign up for that training. Our January spots are, I think, full, and the February and March classes are filling up, but definitely take advantage of that resource. Then also too, I will say our November community of practice, we have those recordings. We did had some really great speakers talk about what our protocols at UK Healthcare, that's not the be all end all, but if you don't have any plans in your practice yet of how you deal with individuals in crisis, we were happy to supply those to you as a starter or something to consider for your own. And then I will also give another plug for the 988 resource. And I don't know if Dr. Hudson, if you want to talk a little bit, because here in the Bluegrass region, the 988 provider is New Vista around here. So I don't know if you want to talk about that resource that's available for primary care practices, not only here, but nationwide.
Yes, so we are the local lifeline provider. So the 24-hour New Vista number, the 1-800-928-8000, rings into the same dispatch numbers as our 988. So it's a lot simpler to access. So they not only have staff available to talk and provide counseling and support, but it also is a direct link to our mobile crisis service, which can go out to the patients where they are and provide that mobile crisis service. Usually within 24 to 48 hours, they can also have a follow-up. So the mobile crisis team has also expanded availability through telehealth. With the pandemic, the silver lining for mental health has been the expansion of telehealth services and the availability to have more rapid access because we cover 17 counties, so there may not be a therapist or psychiatrist available immediately in your county, but with the telehealth capacities now, we can reach out across the network and get people access faster, especially in regards to mobile crisis care.
And there are in other regions across Kentucky similar capabilities that are available through community mental health centers. I know that you all have quite a bit of have expanded your reach, but in other, I know that community mental health centers in other regions also have some of those same capabilities as well. Is that?
Yes, absolutely. Yeah, there's various types of contracts where certain small community mental health centers may contract with a larger one to provide that coverage, but they all have access.
Yeah. Great. We want to just make sure to highlight that, that relationship and that ability to access additional resources. So I wonder too, just again, kind of this issue, in the interest of time, we have this is kind of real quick, is to just address really briefly the issue of patient compliance or buy-in, or, kind of coming back to that issue of like, it didn't work right away, I'm not feeling better. How do you all deal with that in your with your patients?
I think you got to put the time in initially, like when you are having the initial discussion and writing the prescription. It is like, a little bit lengthier than maybe some of the other meds that we prescribe, but it's just it's really worth it because otherwise they come back in a month and they quit taking it on day 2 because they felt nauseated or they had a headache and they thought it was going to last forever. So it's emphasizing that, you're gonna, these are the common side effects. They're usually there for the first couple of weeks and then they go away. So if it's pretty mild, try to push through it. I don't anticipate it's going to last forever. And then really emphasizing that it's going to be about a month before we're really seeing the results, that it's not going to be tomorrow or even next week. And just kind of setting that expectation. And if they feel better in 2 or 3 weeks, that's just like gravy, but you're not, they're not taking it for a week and then just stopping it. And then the other big thing that I tell people is we might have to try a different one. That is pretty common, especially in adults. I probably use a lot fewer agents generally in my adolescents, but for adults, I tell them up front, about a third of the people, we try this, we come back for that 4 to 6 week follow-up and it just hasn't done anything. So we're going to pick another one and try it, and not to be too discouraged by that I won't be surprised if that happens, so that hopefully they won't be too disappointed.
Dr. Hudson, any other comments?
I think that's a great summary. And the other thing that I talk about, like Dr. Meadows was alluded to earlier with the sleep hygiene, is giving tips on how to help the medicine work even better. So things like a daily walk, working on getting adequate sleep, adequate nutrition, increasing social supports, talk to someone each day, avoid isolation, inactivity. So, not just taking the time to describe the medicines, but also going ahead and planting those seeds for the behavioral interventions that help antidepressants work better. And also planting seeds and highlighting the benefits of therapy, even if they're not quite ready or don't have the ability to commit to that, just highlighting some of the research that Dr. Meadows presented on in regards to the additive benefits of therapy and medication. So it's just that, being patient, planting the seeds, watering them, not helping people recognize there are multiple ways to feel better, and all of those can contribute positively. But it does take the added time.
Yeah, great. Thank you. Thank you both so much for your thoughts. That's very helpful. Well, in the interest of time, we're going to do a quick wrap up. So if we could go back to the slides for a second, I want to say thank you, first of all, to Dr. Oros and Dr. Meadows, Dr. Hudson, and Dr. Gottschalk for sharing your expertise. We appreciate so much the insights you've provided. Also, we want to take a moment to invite you all to give us your feedback. We would love to hear from you. So first of all, well, obviously I will go to this slide, which is if you have your phones up, you should be able to scan that QR code and sign up for right now your mental health first aid training. We also have, it's in the chat right there to click on a link. Also, if you don't have, if you're kind of running off to something else, come back to our behavioral health community of practice page where this link is available as well. And we'll also send it as a follow-up email with the slides. So don't forget to take advantage of that training. Second, if we go to the next slide, we really want to hear from you and kind of a couple of different ways. First of all, the QR code here will take you to a survey. We want to hear how we did today, but also in the comment section, we would want to invite you to share with us what you think is working. And if you're interested in being a speaker or have a topic that you'd want us to cover in the coming months, we'd love to hear from you. Please let us know that as well. We've tried to share what we think are some really great brains that are here at the UK Healthcare at UK, but you also have thoughts and ideas about how best to deal with the current mental health crisis. And we'd love to hear from you as well. So send us your thoughts, your comments of either what you'd like to hear, or maybe some thoughts that you have to share, some expertise. Either way, that survey will be the mechanism for us to get back with you and to follow up. And finally, I want to say a big thank you to all of our folks here at UK who've been a part of helping to design and implement this community of practice. Big thank you to our behavioral health team here at UK, as well as our Kentucky Regional Extension Center and Healthy Kentucky teams. Wishing you all the best in 2023. Thank you for being with us today. We appreciate you so much. Take care now. Bye all.